recording now. We do these quite often, so if for whatever reason this doesn't work, Julia, we can always record one of the upcoming ones that we have.
Okay.
Just to let you know, it might be a different audience, but the messaging is the same.
Great. Okay.
But I have started to record, so we'll see how this goes.
Lovely. Maybe just one more minute and then we can go ahead.
Sure, of course. While we're waiting, is there any questions while we're waiting just on the phone? Margaret or Tricia?
No, not that I can think of at the moment.
Okay, no worries. Julia is my contact, so if you do have questions, we'll funnel everything through Julia just for simplification purposes.
Sounds good.
Yeah.
Okay.
And just, it's Karen from Sterile Care too. I think the point of this is just to deliver some education on it. There's a lot to absorb, even though this is just a venous catheter. It's like its own little specialty within inside the catheter. So there's a lot to learn. I think if you just take it in piecemeals, we can come back and do this again if you have more questions after. So I think the biggest part about this is everybody understands the concept of coagulation or clots, bacteria. But if there's one thing that you take away from this, it's the presence of biofilm. So when Sean talks about that, that's probably the newest thing for you to take away, but it is a lot of information. So no, don't feel bad if you don't get it all in one shot. There's lots to learn.
Yeah.
Yes, for sure.
And Julia, what I can do afterwards is send a link to actually a Sick Kids webinar that we did earlier a couple weeks ago. So that's also something that they can view at any time, the nurses.
Sure.
So I'll be sure to follow up with that. That might be an interesting one for people to review.
Yeah, and I do have the materials that you sent me, a couple of PDFs there from a few weeks ago on all of this after the other presentations. So I have that as well. So I'll post that with the video, and then the nurses can kind of review when they get a chance. And I know there was a lot of interest in it. It's just whether or not they were able to make it to the call with their clinic schedules. But anyway, I think we're good to go there if everybody's ready.
Okay, well, I have advanced the slides, so hopefully you can see that. Definitely just wanted to start by thanking everyone for joining the call and thanking you for what you're doing. Obviously, these are unique times, and so any time that we have your attention is valuable. We'll be fairly short and precise here. As Karen mentioned, this is really a dialogue that we're wanting to have with you to help educate, but also pass along some of the information on to those that you work with, physicians, other nurses, etc. You're kind of our voice moving forward. But if you do have any questions, like I said, Julie would be a great contact. Before I begin as well, I do know that there was a survey that was sent out. I think we had about 15 responses or so. It definitely was clear that occlusions is by far the most challenging complication with regards to CVADs that you experience. That was unanimous, as well as the fact that saline and heparin are your two locking solutions to date. So I'll spend some time on that. We'll definitely talk about, obviously, Kite Lock and some of the features and benefits of it. If you have any questions, just interrupt and we can handle those questions as we go. So I do want to introduce Karen. Karen Mueller is our CEO. You can see her on the screen there. The reason we put this page up is to let you know we come from, with Sterile Care, we come from kind of two directions. One is founded on nursing. The other is founded on science. And so Dr. Chantal Linnes, as you see there, is our research scientist. So anything that we present to you today, anything that we speak of is founded in science. So we definitely want to make sure that you're aware of that. We'll go through some points of discussion here. I think the most important thing in here is, as Karen mentioned, we really want to introduce you to a term called the triple threat. This is something that we have been focusing on for the last several years, and something that is relatively new to nurses within CVADs, and that is talking about anticoagulation, antibacterial, and antibiofilm gears that we'll talk about in a second. We call that the triple threat. We'll go over a quick overview of your saline and heparin that you currently use to give you an idea as to what it's doing inside of your lines. And then we'll talk about kite lock. But as I mentioned earlier, from a high level, occlusions, where they're definitely mentioned as being your biggest source of frustration and complications. This just gives you some unique insight as to, you know, the cost of this, the burden it is per day on also not just occlusions, but infections. They're very costly. They increase your length of stay. They delay treatment for your patients. So there is definitely a lot going on. So we will be focusing on this. And again, as you see throughout this presentation, we'll focus on these 3 gears that you see. And that's the clots, the microorganisms, and that biofilm that I had mentioned. So we always like to go back to the basics and understand what is happening. So if you consider these 3 gears working in an interrelated process, each gear moves forward and does not stop until all 3 gears stop. So if you do stop your microorganisms inside the line, the bacteria, that doesn't mean that the biofilm and the clots will stop. So we like to think of this as an interrelated process. If you can keep this visual in your mind as I go through the presentation, I think it will give you a good understanding as to why you see persistent occlusions happening inside of your lines. Again, the object here is to stop all 3 gears. So if we focus on your clots that are caused mostly by blood, we like to always remind people why this is happening. So during the cascade, coagulation cascade, what you find is there is a transaction that occurs between the prothrombin and thrombin. And this is where we try to stop that. So this is where anticoagulants will enter the picture. If you don't stop that process, obviously you get clot formation. And at some point, you have all experienced this, I'm sure. You send that patient back to the hospital where a dose of alteplase is needed to break up that fibrin that has formed inside of your lines. Alteplase is very effective and definitely does work. It's also very costly. So it's also something to keep in mind as we go through this presentation is not only the complications, but the costs associated with correcting these complications. From a science perspective, just to give you a visual on how that anticoagulation cascade occurs, we and other products on the market use what's called a chelator therapy. So if you think of the calcium, for instance, that is formation of your clots inside of the line, we are, think of us as a hand that grabs onto, kite lock grabs onto these calcium deposits and tries to take those out of the clot that's forming so that you break down the structure and you go back to normalcy. Within trisodium citrate, which is a lock solution, this is what we call a 3-pronged approach. So you'll see to the right-hand side that in this case with citrate, it definitely grabs onto that calcium, but because it's called a third arm reaction, it definitely doesn't have a strong binding affinity like tetrasodium EET, as you can see below there. We've got that 4-pronged approach to what's happening. So not all chelators are made the same. Some are very good and some are not so good. It is also important to know that within this lock solutions that this is intraluminal activity only. So there's no extraluminal activity or systemic activity that's happening within these patients. This comes up quite often. So one of the solutions that you currently use is heparin. Obviously, this does stop the coagulation process. But there's a couple things to know about heparin that has been a global as well as a national mandate in the last 2 years. And that is to reduce the use or eliminate the use of heparin as much as possible. And there's 2 main reasons for that. One is obviously you have the increase of HIT, heparin-induced thrombocytopenia. The other is that through a lot of the new research that's coming out, it's showing that heparin produces biofilm. It actually activates biofilm. I'll go into more about what biofilm does, but those are 2 of the biggest reasons as most hospitals and most areas are starting to move away from heparin. So if you are using heparin, please keep this in mind. In the event of a clot, a lot of you, as I mentioned earlier, will be sending patients back to hospital where they'll receive their dose of alteplase. So alteplase works by breaking down that fibrin sheath that has developed inside of the line, as you can see from this picture. One of the things that the fibrin does not do, or excuse me, alteplase does not do, however, is break down that biofilm. So that orange piece that you see in there, if that's biofilm, alteplase does not break that down. It solely focuses on the blood clots that have developed. So what about biofilm? So we do know that the majority of biofilm, or these bacteria, are gram-positive. There's also gram-negative, and there's also yeast. And they enter the system very quickly. Within 12 minutes, you have biofilm forming from this bacteria. And they're in kind of two states of being, if you will. One is what we call a planktonic state, or a free-floating swimming state. The other is what we call a sessile state. And this is where that bacteria starts to grab onto the interluminal walls of your CVAD. And as soon as they grab onto those walls, they start to produce this sticky slime, or the substance, what we call biofilm. So just keep in mind here that there's definitely different types of organisms or bacteria that are in these lines, and they're in different states. So as you can see from this is biofilm formation. So how does it grow within a CVAD? These planktonic states, as I mentioned, are free floating. Once they grab onto the walls of your device, they start to attach themselves, and they start to produce this sticky film, that red and yellow that you see there. And as it starts to produce this biofilm, this is a protection layer, if you will. It's their armor against other lock solutions or antibiotics. They'll eventually get to a certain point where that biofilm grows and grows, and it basically ruptures, and it sends forth new bacteria that goes back into that planktonic cell state, so swimming state, and that cycle will continue on and on until it's stopped. And there's several ways in which you can stop this through different lock solutions. One is what we call MIC. This is the minimum inhibitory concentration. So this actually stops the growth of these cells. Other solutions will actually kill the bacteria. That's the minimum bactericidal concentration. What we call MBC. Again, these are fairly scientific terms, but this is the killing part of the bacteria. But if your lock solution does not address the biofilm, what we call the MBEC, where it eradicates biofilm, this cycle will continue on and on. And so no matter what type of lock solution you will use, you will always have infections and occlusions occurring until this is addressed. So just to give you a couple of visuals, this is a representation of a line inside of the vascular system, just to show you what biofilm looks like. Again, I'd mentioned earlier that the bacteria starts to colonize inside of these, forming biofilm within about 12 minutes. And we know that within about a day's time, the catheter will be covered in biofilm. This is a very well-known phenomenon that occurs. We also know that this is the source of 80% of central line associated bloodstream infections, or CLABSIs. And this is a continual source of bacteria, and that they're finding lead to superbugs. So a lot of time these superbugs, the bacteria, will hide underneath that slime or that protection layer. And what they do is they start to transfer their information to each other on how to resist things like antibiotics. And so they start to become these superbug formations. Again, water pipes, you'll see them on rock in a river, all that green algae. You know, that's all the slime that you see inside or outside in nature. But inside the line, as you can see from my B representative there, that is actual biofilm formation within a dual lumen catheter. So you can see that this would look very similar to fibrin buildup or a blood clot, but in this case, it is biofilm. Within the antimicrobial agents, again, we talked about the chelators, or that calcium affinity, where they grab onto the calcium ions inside of the blood itself, so it doesn't form coagulation. It's very true when it comes to the antimicrobial properties on how it destroys these cells as well. I had mentioned earlier that gram-negative and gram-positive, as well as yeast, is different types of bacteria that can be found inside of these lines. But as far as biofilm is concerned, only the EDTA will eradicate biofilm. By the same token, it will grab onto these calcium ions and break down that slime so that further solution can penetrate further down and essentially eradicating all the biofilm within these lines. Again, we mentioned this several times because it does come up, but again, this is intraluminal activity only, it's not systemic. So to give you a visual, again, I like this quite a bit. It helps me understand what's actually happening. If you have a lock solution that does address the bacteria in your line, that is great. However, we still have to consider those blood clots. So if you do not have a device or a lock solution that addresses that, you will continue to have these blood clots. If you do introduce an anticoagulant solution, you will get rid of these blood clots. But as you can see, if they're hiding underneath of the biofilm formation there, you will not get to those clots. So not only, and those clots or that cycle of formation, as I mentioned, will continue on releasing new bacteria into your cell or into your catheter as we continue. So it's important that we, A, eliminate the bacteria, we break up that biofilm, we get rid of the bacteria altogether, and we continue to break down that biofilm so that we get to the root of the cause, we eliminate all of the biofilm that's formed, and we may need administration of alteplase to clear up that line from the blood clots that have formed, leaving us with a nice clean line. So I won't go too much into this here. It's more of a discussion about AMR, antimicrobial resistance. But I did want to review with you two solutions, your saline and your heparin. Again, the difference of these is that we have some misinterpretations that KiteLock is a drug. So we just want to be sure that everyone's aware that we are a medical device first and foremost. So we do not affect individuals systemically. It is only intraluminally that we're affecting individuals. Again, we need to knock out all these three gears in order to consider the cascades of anticoagulation and antimicrobials from occurring. So that is important. So as you go through this, think about these three gears and if your lock solution currently meets that need. So I've done a comparison here just quickly to show you your saline heparin. Again, this is identified as your two lock solutions being used. Again, if we look at the anticoagulant, antimicrobial, and antibiofilm properties, you'll notice that saline does not meet any of those. If we look at heparin, we do have, that's in the wrong spot there, we do have the anticoagulant properties occurring, but we do know that heparin does stimulate biofilm and there is risk of hits. So we do know that it's not addressing all of those three gears. It's definitely not getting rid of biofilm. It's definitely not an antimicrobial. So as we look forward to new lock solutions, the new era of lock solutions, this is where KiteLock enters. Some of you may notice the term EDTA. This is disodium EDTA, at least is found in your lavender blood collection tube. So it is something that has been around for quite a long time. So it is a well-known solution that's being used. Again, I mentioned that it's effective at gram-negative, gram-positive, as well as yeast strains found within these lines. But not only does it prevent, it also eradicates the biofilm. So it is the only device in the world, actually, that has been proven to do so. And we support this antibiotic stewardship program. So we are a non-antibiotic lock solution as well. I'm going to pause there just out of the interest of time. There's about 7 minutes I have left. We do have various studies. Again, I won't go into these in too much detail, but these do show essentially different concentrations will break down the different strains of bacteria that are found within these lines. So this is just showing you different concentrations, and then also the exposure time to eliminate these different strains that are found will depend on the type of strain. So in some cases, They will need to be exposed up to 24 hours of kite lock to completely eradicate the biofilm and the actual complications that are occurring. I won't go into them too much. Like I said, we definitely have this. A real high level though, what we're seeing is that through these studies, on average, we're seeing a 50 to 70% reduction in alteplase use, or that are happening, and we're seeing on average anywhere between 70 to 100% reduction in bloodstream infections. Again, this is dependent on which study we're looking at. So we do have studies. This one here that I'm showing you is out of sick kids here in Toronto. You can see there's a 100% decrease in infections and a 50% reduction in alteplase use. So there's quite significant findings here, which leads itself to financial savings as well, which we've also showed here in this example here of South Lake, the financial evidence. But before I go on, Julie, I'll pause here. We've got about 5 minutes remaining. I want to make sure I have time left for any questions that you have. So I'll stop sharing. Maybe I'll end on this because this is quite interesting as well, just showing you the safety profiles for kite lock. I'd mentioned that this is a chelator, so some individuals are concerned about how that affects systemically, but you can see there that we're well within the limits of what's acceptable tolerance. So again, this is work done through sick kids. They actually were aspirating kite lock in their CVADs, but because of various scenarios, they now flush kite lock into the patient's system. They've been monitoring their blood serum levels and have had no effect on those patients, and we're talking 5 kilos or more. So just want to throw that in there. So I'll stop there. I wanted to get just a pulse check, Julia, on thoughts, feedback. We've got 6 people I see here. So any feedback on what you've seen or any complications that you know are happening that you'd like to be addressed?
Not really. No, I think that was great coverage, kind of the, reminding us of all of this helpful information about how the clots and all the various concerns. I think it's really well presented. In terms of this actual product, and so last year we did update our CVAD policies to lock with heparin, understanding or thinking that was the recommendation, say according to CIVA guidelines. Is the product mentioned at all in CIVA guidelines, or was that before? Like, I'm just curious if how that kind of falls within CIVA guidelines, or if you're aware of that.
I'll let Karen. Yeah, Karen.
I can actually speak to that. Yeah,
I was hoping you would.
I was part of the guidelines. Yeah. So when it came to discussing lock solutions, there was major controversy on the stance that we would take. We reviewed all of the guidelines around the world, and there was a thread of people still indicating you could use heparin, although there was an underlying movement to move away from it. So in the 2017 Accreditations Handbook for Canada, it actually says in there to move away from heparin because it's a high-risk drug. So in the guidelines, we decided with a soft approach, we're going to put it in there because we can't expect people to change tomorrow, with an understanding that there is a goal to move away from heparin. Then we talked about alternative lock solutions, and all of the ones that Sean kind of briefed over are all listed in there, and then it's up to you to choose which lock solution is going to meet your needs. So again, heparin, because biofilm is such an unknown quiet culprit that we've really not talked about before, it's now in the limelight. So when you're working with your patients, I think it's important just to do that risk-benefit ratio. Is your patient prone to infection? If they are, absolutely you don't want heparin in there because you're going to increase the risk. If they're having lots of occlusion issues, then you need to have an anticoagulant. So heparin can help you with that as long as you don't have infections. So, it's not always best case scenario. It's just walking through what can we do for this patient in front of us. Does that make sense?
Absolutely. Nope, that's really helpful. Thank you.
Mm-hmm.
So there's some countries that don't use heparin at all.
Good.
So we'll get there, but slowly.
Yeah, no, and we're still seeing that. So we have patients with CVAD all across Canada. They're definitely the minority. Like most of our patients I know we do upwards of 60 or 80,000 infusions a year across the country. The vast majority are short-term. You know, we insert an IV when they come and it's gone by the time they leave at the end of the day, but every clinic has a few CVADs, and generally they're long-term chronically ill patients, and they just have poor IV access from long lifetimes of whatever their health issues are. And we still see a great deal of orders for heparin. And we still see, you know, the clotting issues, and obviously that came up in the questions and such that the nurses submitted. I only knew more about sort of the move away from heparin towards saline locking because of SIVA. And then kind of when we started talking to Sean, that's when I learned a little bit more about it. So I'm interested to kind of go back and see how things are worded in the guidelines and try to update our policies to support that and try to get that information out to our nurses as well. Not that we're typically not the ones who get to decide, but again, if we have that knowledge that, you know, that's how things are moving, that can only help. So
really 100%, you're totally on track. So now that you guys have this information as clinicians, it's about education. So if your patient has long-term catheters and they're having occlusion issues, now you know to go, it may not just be clots, it may be biofilm, because if alteplase is not breaking it down, why is that? Is it extraluminal, or is it because it's biofilm protecting the clot, or it's just biofilm, right? Yeah. So lots of things for you guys to take away from this, but love the thought process. And, you know, patients with long-term catheters are compromised. So some can fight that bacterial shower that they're getting from the biofilm, and some can't. Yeah, well, and absolutely. And our patients are immunocompromised. That's typically what we're giving them through those CVADs is, you know, immunotherapies. We're moving into kind of immunotherapies with oncology indications as well now. So, and they're often the ones that do come with CVADs because they're often getting concurrent other therapies, say in hospital and stuff. So sometimes we're only getting them for every other flush or every other treatment, or, you know, every other month and stuff like that. So there's somatic complications, but it's this is really interesting. And I really like that you cover well the kind of the other considerations and explain how the biofilm, you know, develops and all these other things and what each of these products do and don't do. Really helpful information.
Yeah, I didn't go into, I mean, there are other solutions you may come across as well. Citrate is another one, but again, if you try and think about those, I guess I have two takeaways. One is to let you know that Kite Lock is being used throughout the entire country, and there are other locations within the world that are using as well. The other is that as you come across the complications, it's what we're trying to not challenge, but ask nurses these days is to stop and think if there's something actually else going on inside of the line, and to not just necessarily grab your alteplase and expect that that's going to solve your problem. You now have known this, the information we've shared, so we're trying also to have nurses become our educators as well, that if this happens and they have a physician they work with, we're more than happy to work with you or the physician to have a bigger discussion about the use of Kite Lock. Because we know that the problem is getting worse. We know that hospitals are using, in some cases, antibiotic lock therapy, which again, from a global standpoint, is something they're really suggesting that we don't do. We're adding to the resistance, which I didn't go in the slide, but there's one slide that shows that it's a much bigger global threat than COVID-19. By 2050, they're estimating that these superbugs will kill about 10 million people a year.
Wow.
So it definitely is something we're asking nurses to keep in mind. Share the information to the physicians as you see fit. If you work in a hospital setting, what is it you're using? Are you seeing complications? How much are you spending on alteplase per year? And all those questions, I think nurses are going to be quite shocked if they did some fact finding.
Yes. Very good.
That was a lot for 30 minutes. You guys have absorbed it all?
That was my quickest presentation, I'll admit.
No, that's it's great. If we do have any follow-up questions, I'll certainly circle back to you, Sean.
Yes.
Thank you both very much for your time and making a little presentation just for us, and you know, focusing on kind of the stuff that we see. So much appreciated.
Anytime, we're all about education, so let us know what you need and we'll help out as much as we can.
Great. Thanks so much, Karen. Thanks, Sean.
Thank you so much.
Thank you. Everybody have a good day.
You too.
Bye. Thank you.
Bye.
Bye. Thanks.
Bye.